the impact of Covid-19 pandemic over HIV. The times were difficult for all of us during the pandemic. We have all learned so many lessons, and today, as I see mask-free people, I feel very happy. So, we have won over the battle, and with this background, I would like to start my presentation with the following objectives. To know the impact of COVID-19 over HIV testing and reporting services, opportunistic infections occurring in people living with HIV/AIDS, and treatment and vaccination over HIV referral services. By August 2020, 24 million people were diagnosed with COVID-19 worldwide. Alarmingly, South Africa and India were the countries with the highest COVID-19 burdens. 40 million people living with HIV were over age 50 in several countries, making age as an important factor. These are the two viruses, HIV virus and SARS-CoV-2. Though they belong to different phylums and subfamilies, we will see a few differences between them. HIV virus belongs to phylum lentivirus, whereas SARS-CoV-2 to beta coronavirus. The size of the HIV virus is 100 nanometer, whereas in SARS-CoV-2 is 50 to 200. The targets for HIV virus are CD4 cells, and for SARS-CoV-2 are ACE2 receptors. Incubation period is 2 to 6 weeks in case of HIV and 2 to 14 days in case of SARS-CoV-2. The non-human primates are the animal reservoirs for HIV infection, whereas, as we all know, the bats are the animal reservoirs for SARS-CoV-2. The early infection in case of HIV is mononucleosis-like symptoms, and in chronic cases we get opportunistic entities, and if not treated, HIV turns into AIDS in about 10 years. Whereas in case of SARS-CoV-2 or COVID-19 infection, there is difficulty in breathing and fever in the initial cases, whereas in severe cases, there is pneumonia, kidney failure and death. Coming to prevalence of HIV and COVID-19, in a cohort-based study of Vizcara et al. In 2020, 51 out of 1,339 cases of people living with HIV, they contracted COVID-19, giving a prevalence of 3.8%. In a study of New York area hospitals by Richardson et al. In the same year, 2020, prevalence of 0.8% was noted. Prevalence of HIV in COVID-19 in patients was as low as 0.26% in Catalonia, Spain, and to as high as 4.17% in Seattle, USA. So what are the risk factors? Now, HIV as an independent risk factor for severe COVID-19 at admission and in hospital mortality. Older adults and patients with underlying medical conditions like chronic respiratory diseases, cardiovascular diseases, hypertension, cancer and diabetes, these people are more likely to get very sick if they contract COVID-19. So median age for people living with HIV, AIDS and COVID-19 was a decade lower than individuals without HIV, as suggested by multiple studies. The reasons could be multifactorial. There could be higher prevalence of comorbidities, increased occupational exposure, and other socio-economic factors. Coming to pathophysiology, the HIV virus depletes CD4 cells, leading to immunosuppression. It reduces capacity of the organism to defend against bacterial, fungal, viral and parasitic infections, for example, COVID-19. In people living with HIV/AIDS, there is dysregulated immune system, and patients who are not on ART there is increased risk of opportunistic infections. Among patients with COVID-19, there has been seen to be high levels of pro-inflammatory cytokines and chemokines, which leads to an increase in the severity of COVID-19 infection, higher consumption of CD4 and CD8 cells, decrease in regulatory T cells, and altered innate immune environment, which leads to cytokine storm. In people living with HIV/AIDS, antiretroviral therapies are protective against COVID-19. However, the data is uncertain. Tenofovir, which acts on the RNA-dependent RNA polymerase and blocks viral RNA synthesis, it forms the backbone of first line of ART in HIV-1, and now it is being actively studied against SARS-CoV-2. Molecular docking studies show that tenofovir binds to SARS-CoV-2 RNA polymerase to a similar extent as remdesivir. However, protective effect of tenofovir or protease inhibitor remains inconclusive. Potential benefit of protease inhibitors in COVID-19, such as lopinavir and ritonavir, they slow the disease progression and improve the prognosis of the patients. Coming to vaccination for COVID-19, in HIV positive patients who receive ART have a lower risk of COVID-19 and related hospitalization. People on ART or with low viral load are less likely to be admitted with severe COVID-19 and less likely to die. This backs the decision for people living with HIV/AIDS to be a priority group for COVID-19 vaccination. Now, what is the social impact of COVID-19 on HIV? It is essential to recognize that all pandemics have biological, psychological, and social implications. In COVID-19 pandemic, there was an increase in number of people living with HIV who sought mental health services for anxiety, depression, and other mental health related concerns. Among these people, depression is the second most common mental disorder and constitutes an additional barrier to HIV care. Healthcare providers play an important or crucial role in the preparedness and global response. Despite the potential benefits of telemedicine for HIV care, the limitations are client confidentiality, establishment of rapport, therapeutic alliance between client and healthcare provider. So what was the impact of COVID-19 over HIV services? Most consistent research findings for people living with HIV during early COVID-19 were concerns that lockdowns would reduce access to HIV care services. We had national lockdowns, and therefore there were concerns that the access to HIV care would be reduced. It was widely expected that COVID-19 would interrupt access to ART for HIV with adverse effects on adherence to treatment, access to pharmacies, and impact on stress and substance use. Globally, estimated that 1 in 5 people living with HIV/AIDS were unable to access their HIV care provider. Close to half of these people were unable to access ART refills remotely, least access occurring in Brazil, Kazakhstan, Mexico, and Russia. In Argentina, 8% of such people were unable to take their ART during early COVID-19. This bar diagram shows the trend in HIV testing during COVID-19 pandemic. As it is evident from the bar diagram, in the years 2017 and 18, the testing and the positivity reporting has been consistent. We had COVID-19 in the year 2019 December, where so the figures are consistent there, all the three in 2017, 18, and 19. Whereas there is a downfall in reporting and positivity rate from 2020. You can see it in 2021 also and up to 2022. So to conclude, COVID-19 has had an impact on HIV disease progression, disease positivity, HIV referral services, HIV ART services, loss to follow-up, and reporting services. COVID-19 was a priority for all of us. Only emergencies in healthcare were entertained. Late detection led to severe progression of the disease, and that led to increased morbidity and mortality. And decreased adherence to HIV treatment led to increased progression and increased hospitalizations. The supply chain management was disturbed, leading to disruption of ART pickup services. Given the stigma and stress associated with HIV positive status, we need well-coordinated efforts to combat COVID-19, partnerships and synergies between public health programs, healthcare providers is needed, HIV programs for proper screening and serologic testing for asymptomatic people living with HIV, and management of persons with COVID-19 and HIV positive status. Scientists and practitioners are encouraged to continue to contribute their efforts to reduce health disparities in pandemics. The informal slogan that "we are in this together" will continue to ring true to our responses to current and future pandemics like HIV and COVID-19. Thank you.